You can't replace part of the brain. Like, you
treat them the same.
Source of truth for the medtech industry.
Coexists with the prophets.
Robot understands things automatically.
Number one show in the medtech industry.
So Stryker got ahead of that and changed in the $90 billion company. They help apply a lot of things. The State of Medtech.
With your host, Omar M. Khatib.
What's going on, everybody? Welcome back to the show. Excited for our guest today. We have Dr. Catherine Mohr, who's not only the president of the Intuitive Foundation, but also the cover of one of my favorite magazines, The Lens by LSI, for the February edition with the title Solving Wicked Problems at the Intersection of Healthcare and Technology, Insights from Intuitive Foundation's Catherine Mohr. Dr. Mohr, thank you so much for joining the show. How are you doing?
I'm doing well, thank you, and thank you for having me.
Absolutely, it's been a long time coming. This should have happened a long time ago, but I'm glad we're able to do it. And you're very busy, so I appreciate you spending some time with us. Maybe for to start, for our listeners, for just learning about you, give us a little background about who is Dr. Catherine Mohr. Like, where'd you grow up? Your training, and then we'll kind of get into the Intuitive Foundation.
Well, I'm a New Zealander originally, but grew up in the States. And
does that mean you're a Kiwi? Is that the right?
Actual Kiwi, yes.
You're a Kiwi. Oh wow,
yes.
Okay. You're you know what? First Kiwi on the show, I think.
All right. Well,
yeah.
There we go. Got to represent down under.
Absolutely.
So,
yeah.
So I grew up in the States, mostly up in the Boston area in New England, and trained originally as an engineer, a mechanical engineer, worked in robotics, and then went on to do work in hybrid electric vehicles, high altitude aircraft, and then got a wild hair in my 30s and went to medical school and trained in surgery. So yeah, the short form is engineer turned surgeon turned global healthcare strategist.
That's amazing. That's I would say, like, we've had some pretty amazing guests on this show. That's probably one of the top skill and talent stacks I've ever heard. What made you want to go to medical school?
Ooh, well, I was managing people who were doing what I'd originally gotten into engineering for. So I'm very much a tinkerer and a doer and not much of a manager. But I also really thought in terms of tinkering with the human body would be the ultimate. I fell in love with surgery, and being able to take something apart and put it back together again and have it work better was really appealing. Well, I learned a lot more about surgery, and that's not exactly the way it works, but that really was part of the thinking process as I did that mid-career shift.
Amazing. And what kind of led you to Intuitive? And I think for the audience as well, what's the difference between, let's say, Intuitive Surgical and Intuitive Foundation?
So what led me initially to Intuitive is that my husband, when we moved up to Northern California so I could go to medical school, he took a job at this funny little startup called Intuitive Surgical. So that was back in 2001 when they were just getting the first FDA approvals. It was still the old black machine, the first one. And so while I was in medical school, I was seeing somewhat behind the scenes of how the next generation Da Vinci was being made. That was the S, if anyone remembers back that far. And so as a medical student, I was doing a lot of work in surgery and started developing procedures for the Da Vinci. So I developed a Roux-en-Y gastric bypass, worked with my, I guess she was my attending at the time. She's been my boss now for the last 20 years. And we developed surgical procedures for this new robot. When I was finished with medical school, they were like, we kind of like the way you think. And I took a role running medical research.
I love that. And it makes a lot of sense too, because I always felt that Intuitive in terms of its culture was very much, on one side, very marketing led, but at the same time, engineering led in terms of the discipline and focus. And we definitely see that now with Gary as the CEO, who's, I think he was employee number 4 or 5 at the company as an engineer, seeing that you kind of had this front row seat to Intuitive's rise. And again, you knew about the company when it was going through its dog years. So those early 2000s were really, really tough. So we can say that back then it was very much like a misunderstood startup, and now it's a dominant category leader. What do you think were some of the sort of let's say, non-obvious threats that nearly derailed the company, and how did the company sort of navigate those things?
Yeah, I think there were definitely some early challenges in regulatory because no one really knew how to regulate this. Is it software that you're regulating? Is it the hardware that you're regulating? Is it the actual application? And so the evolution of the company and its products happened along with the evolution of the FDA's sort of thinking about this kind of technology. Um, I think early on also there was a lot of, gee, this is a solution in search of a problem. And people didn't really recognize, they were always thinking in terms of, oh, this is a competition to laparoscopy, as opposed to thinking about it as expanding the universe of minimally invasive surgery. And really, it was competing against open surgery. That was what we wanted to bring down. And so there was so much, oh, we've got to think about it in comparison to lap instead of really thinking about it in comparison to maximally invasive surgery. And it took a while, I think, really for the rethinking to happen.
Yeah, and I think, it was interesting. The one sort of famous saying that I think from back in the day was that Intuitive was sort of aiming for the heart and missed, and ended up hitting the prostate, and that worked out for the better for patients.
Yes.
So
Well, and that story, which is really, very, very true, it underscores how difficult it is to find that perfect match between a technology that can solve a problem and the problem that really needs solving. And there were a lot of training issues with getting into cardiac. And, Intuitive is getting back into cardiac now. But in the day, really being able to do an isolated procedure in a single specialty that was more amenable to being a longer case. You didn't imperil the patient if it was longer. It was that set of requirements that actually made the app that could grow. Yeah.
Everybody, quick break. If you're a medtech CEO or product leader, you're going to want to listen to this sound. I want you to imagine you're about to have a product launch. You've poured your time, your budget, your reputation into a device you're about to launch. And after all of that effort, your FDA submission, poof, gets rejected because of cybersecurity. This sounds dramatic, but it's actually not. It happens all the time to medtech companies, especially recently with everything being digitized. This happens so often because medtech companies treat cybersecurity as a checkbox when it's now a non-negotiable design pillar. The FDA's 2023 guidance didn't suggest cybersecurity, it demanded it. So if you're not ready with threat modeling, penetration testing, SBOM management, incident response, and airtight documentation, you're not launching, period. And here's what most entrepreneurs don't realize. Scrambling to fix these issues last minute can cost over $250,000 and delay your launch by months, which imagine the investment of getting delayed, right? The more you spend time in review limbo with the FDA is lost revenue, lost market share, and lost investor confidence. And yet, so many founders and entrepreneurs I talk to, they still treat cybersecurity as a postscript instead of a strategic advantage. Now, I've held off bringing this to my audience as a topic until now because there just wasn't a medtech-focused cybersecurity firm that I trusted, and that changed when I found Blue Goat Cyber. They specialize exclusively in medtech cybersecurity. They've helped companies like bioMaru, Inogen, Natera, along with nimble startups to get to market faster with a 100% FDA success rate. I had the chance to meet the founder, Christian Espinosa, and his story really resonated with me. So after he sold his first cybersecurity company, Alpine Security, Christian actually faced a personal health crisis. He ended up in the hospital, and that moment made him realize how vital and vulnerable medical devices really are because a medical device saved his life. So he built Blue Goat to serve medtech CEOs and founders just like you. Whether you're pre-revenue or scaling fast, Blue Goat can offer fixed-free pricing, unlimited retests, and no surprises. This isn't bolt-on security. This is built in from day one.
You wouldn't launch a device that hasn't been clinically validated. So why would you risk launching one that's vulnerable to attack? Blue Goat will secure your device, simplify your submission, accelerate your approval, and they'll do it in a way that fits your budget, your timeline, and your team. So here's what I want you to do next. Go to bluegoatcyber.com, schedule a discovery call. They do these amazing calls. They'll do an analysis with you, educate you more, because the cost of waiting could be everything that you've worked for. So that being said, go to bluegoatcyber.com and schedule that call now. Let's get back to the episode. You know, you served at Intuitive as their head of strategy and made this transition to Intuitive Foundation. So, before you dive, sort of deeper, especially on some of the topics you covered in your cover in the lens, what is the Intuitive Foundation? What does it do?
So I went from running medical research, where we did a lot of grant-driven grant-driven support for various people who were wanting to do outcomes-based research. I later moved into emerging market strategy. So I spent a lot of time really looking at healthcare systems in India and in China and in some of the lower resource environments where we were looking at, does it ever make sense to have robots here? And during that work, I became very hyper aware of the demographic tsunami that we had coming at us, that there were going to be so many more people in the middle class in these countries that we tended to think of as poorer countries, and that this demographic change was going to happen, and our educational systems for clinicians were not going to be able to keep up. We did this very apprenticeship model type training. And so I put the foundation together in 2018, really to allow a pivot in focus. We kept all of the grant programs for outcomes-based research, beefed up the philanthropy that we were doing. But the real reason I was putting the foundation together was to address this big global problem of training. And it's been quite a ride since 2018 when we put it together. And most of my focus these days is really improving the scalability of training in low resource environments.
I love that. And I think that's something that is not talked enough about. So a lot of people may not know this about me. So I actually went to medical school back, in Texas. I ended up leaving about halfway through. But, if we look at medical education, a lot of it is pretty archaic and ossified. And I think it was able to sort of skate by over the years. But now with, I think Mohr's law of technologies and like hyperdrive these days. And so to be able to keep up with like new technology and the adoption and applications of it, like we have to change the way we educate and train. Do you feel like a lot of this is going to extend also down to the level of even medical school?
So, but it's not my first target. And when you look at historically how we have grown the training in professions like medicine, it's a guild system. You have the elders who know how to do this, and they impart in a professional society the wisdom and knowledge on how to do this to this next generation. Very much the apprenticeship model. We joke, see one, do one, teach one. But in a replacement type population, so you don't have a huge growth or explosion of young people. You've got the same number of young people coming into the population as you have old people, kind of exiting the population at the top. But it's okay to have long training times in that sort of a situation, because as people are retiring, you've got new people coming in. Those systems were not designed for the type of population growth that we're seeing in Asia and in Africa. And so if we continue to train in ways where these systems grew up in Europe and the Americas, where we have much more like a replacement population, we're just going to fall further and further and further behind. And so understanding that it wasn't inevitable that we trained in this slow, deliberate apprenticeship type way. It was just more socially acceptable. It kind of let you train for longer, but not sort of glut the market with lots of clinicians. But that there should be alternate ways in which we do this that we can keep very high quality without keeping that same apprenticeship model that we've always had.
I completely agree. And you mentioned Asia, so how about a sort of a data question for you? So LSI is our trusted partner. They have an amazing team of trusted market intel researchers and experts. So they just released this really interesting graphic the other day about APAC. And so they showed that the APAC region accounts for about 22.9% of all medtech sales worldwide, and the CAGR for it is about 8.4%, right? And the reason why that's pretty significant for the audience who's listening is that CAGR is essentially outpacing the global medtech market's 6.6% CAGR from 2024 to 2029. When you see something like that, how do you interpret that? How do you look at Asia and APAC?
Well, I look at both Asia and Africa through this lens of rapid growth, both in the GDPs of the various countries, but also in the relative youth of the population, and the need for those populations to be able to have healthcare. You look out to about 2020 to 2050, 25 years from now. We've got getting close to 10 billion people on this planet. The last projection I saw was like 9.8 billion people. 25% of those will be in Africa. 55% will be in Asia. And we've essentially got 20% left over for the rest of the world, which is Europe, the Americas. Only 13% of that is what we think of traditionally as, like our high income Western countries. So when you're looking for, as a device manufacturer, as someone who is going to be thinking about the future of healthcare, everything we're doing right now, focusing in Europe and North America, is going to be only 13% of that population in just 25 years. And so you have to think beyond kind of the traditional wealthy markets. When you think about the economic changes that are going to be happening, Bloomberg and other radicals like that have projected that in the top 10 economies, you're going to see Indonesia, Nigeria, and Egypt. Those are not sitting in the world's top 10 economies right now, but they will be growing at this pace to be entering. And so you have to be thinking about a long-term strategy that doesn't look like our current strategies.
Yeah, no, I agree with you on that. And just to kind of piggyback on that, I'm going off the top of my head. I don't think I'm wrong on this, but every place in the world currently has like a declining birth rate issue, except for I think Africa right now. And actually, Africa has a very large population of young people, and so everything, at least market trends and everything, points to that.
Absolutely. And Africa has a lot more arable land than people think, oh, there's famine in Africa. Well, famine in Africa comes from some of the agricultural techniques that aren't using irrigation and, don't have some of these technologies. These are fairly fundamental technologies that, when put in place, make land just that much more productive. And so there will be population growth in Africa that will be sustained by its landmass. And there isn't really the kind of limit on it that you see us running into places that are considerably more crowded. And so, it's going to continue to grow and thrive and change in terms of its the various countries, their role on the global stage. And it's just going to be amazing to watch.
Absolutely. So like on that note, when we talk about all these different opportunities, going back to the cover issue of LSI and the idea around wicked problems. So you kind of identified that as the gap between what a clinician wishes they can do, wants to do, and what's actually possible. And of course, in the age of all these different opportunities and problems to solve, like how do you essentially decide which problems are worth tackling and which ones should you wait for in terms of the right moment. I think this is such an important thing. People always say like, oh, Mohr, why do you use Intuitive as such a great example? I'm like, well, when you become one of the biggest companies in medtech in a period less than 20 years with extreme discipline and focus and all these things and ability to disrupt yourself, I can't help but go back to that. So I'm wondering, like, how do you think about picking the right problems to solve?
Yeah, that's definitely the strategist question, which is there are a lot of problems out there, but you can really bust your pick trying to solve one that a lot of people have already tried to solve if there isn't anything new. And that's the key. So you really want to characterize the problems that are interesting, those wicked problems that are gaps, things that we really want to do, but that we're not capable of yet. But if you get a new idea or a new insight or a new technology or a new approach or something new becomes acceptable, like, for example, we're doing this remotely. Nobody thought about remote teaching until we had a pandemic that forced us all into figuring that out. So we have a new mindset that you can now start to close wicked problem gaps with, that in the past you would have had to first convince everybody that they could do things over Zoom, and then you would be able to solve this next problem. So you tackle one of these wicked problems when something has changed. And you've either, in our case, generally we're keeping an eye out for advances in technology that would, in Intuitive's case, advances in technology that would allow kind of a new capability. What am I looking for on the foundation side? I'm looking for advances in ways in which we could do assessment over a distance, whether that's by video or being able to do an AI assessment of someone. So it is, you keep carrying around your wish list, and when you encounter something new that's changed, a shift that's changed, that's happened, you can then match that up to this wish list that you've been carrying around, and time to do something and try to solve one of those wicked problems.
Absolutely. So, covering on sort of the tail end of a great example of that is if we look at Ion, the Intuitive Ion system. If we look at it today, at least from our research, we found that over 100,000 procedures have been done. Before Ion existed, lung cancer screening was always kind of a diagnostic nightmare. It was very slow, it was very expensive, psychologically brutal in many cases. So how did Intuitive think about like sort of reimagining that patient journey, and what are you seeing now after doing 100,000 procedures, and how do you apply that to sort of the next thing?
So there were a lot of pieces that came together. There was a shift in technology, there was a shift in perception, there was a shift in evidence, and there was a shift in attitudes that was all sort of happening around that same time. So we had on our list of wicked problems quite a few that needed a flexible robot. So whether you were going to snake a robot down into the lungs, or you were going to snake a robot up through the colon, or you were going to, go down the esophagus and do things in the stomach, there were a lot of problems that if you could do something useful at the end of a flexible journey, that you could do something clinically significant. When the Luna fiber came out, this was the fiber Bragg grading fiber that allowed you shape sensor over a distance, and you were going to be able to tell the pose and the position and the path that fiber had taken. It was not perfect at the point. It couldn't do that fast enough yet, but we could see what it was possible to do and know that you could close a control loop around something like that. So that started to open up the area of, okay, now it's potentially time to start solving some of these wicked problems that need a flexible, a long, flexible robotic solution. The clinical change, as we were looking at all of the possibilities, was the National Lung Cancer Screening Trial was going on. And prior to that, no lung cancer screening trial had ever shown a positive effect on morbidity or mortality. You killed more people with screening than you saved, because when you screened and you saw a suspicious nodule, more people died in the workup of those nodules than were ever saved by the cancer screening. So they had taken a good hard look at that. They did a better trial where they did a pre-test probability. They were 55 pack year smoking history, 55 years older, sorry, with a 20 plus year, 20 plus pack year smoking history. So that is 2 packs a day for 10 years or more. And if you just screened people who met that requirement, suddenly it was looking like you were going to have a really positive effect on lung cancer deaths, because you were going to find these nodules at a point in, when you had an 85% chance of them surviving versus about a 15% chance of them surviving 5 years if it was found kind of in the normal way, just because symptoms started to happen. And so we had this new technology. We could see it was potentially going to be getting us the ability to close a control loop on a flexible robot. We were looking around at attitudes and clinical evidence, and we thought that when the results came out from that trial, that there would be a sea change in terms of how many people were then getting screened. And as you looked at just the pain and suffering associated with being screened, we thought we could do something much better there, that we could really help narrow that gap, because we could get a tissue sample when the nodule was still too small to be able to call it one way or another radiographically. And we could get that tissue sample without putting the patient at huge risk of getting an air leak and having a chest tube and being stuck in the hospital for that period of time. And so we were bringing something, as we were putting all of those pieces together, we anticipated a change in insurance and reimbursement and screening sort of policies. We were expecting to be able to really change the experience for the patient, because it would be not weeks or months of waiting until their next CT scan, or a week in the hospital with a chest tube after a transthoracic biopsy. And so we could really move the needle in terms of how invasive and difficult that would be for the patient. And we were bringing out the technology that was finally enabling us to be able to have the kind of tight control that we would need to be able to biopsy those very small nodules. Because if we weren't biopsying very small nodules, we weren't going to move the needle on survivability. So it was a combination of several things that all happened that allowed us to say, this is the problem to focus on, and brought the shape sensor, the catheter, and a new focus on diagnostics to the company. And that was the genesis of the Ion product.
Quick commercial break for marketing leaders and sales leaders. I don't have to tell you this, but it's worth reiterating that the time clinicians have to meet with medical reps is limited. You know this and feel this. It's been a challenge for med device sellers for decades. Now, with the rising workloads and patient care demands, clinicians' times are shrinking even more. And the window for your sellers and your sales team to meet with these clinicians consists of pretty much just minutes in a busy hospital hallway. The reality is your sellers have to make every second count, or someone else will. They must be concise, they got to be efficient, and use highly relevant information to make the most out of these brief interactions. Showpad is all about focusing your sellers on the art of selling, which is about building trust and relationships. And while there's science, the Showpad solution handles the behind-the-scenes prep and follow-up work to make your team more effective. The best part is that you get insights on content and training performance, so you can make strategic decisions and invest more in what works based on data. Showpad helps your sales and marketing teams spend their time in more productive, high-impact ways with a multiplying effect on your revenue results and growing your pipeline. So to learn more, go to showpad.com/State of Medtech. Now, let's get back to the show.
What's really interesting is that there was this coming together of like a bunch of frontier technologies that made ions. So you have robotics, navigation, imaging, real-time feedback. And I wonder, a lot of times these quote unquote frontier technologies, if I go back like even 10 years ago, like you would have something like that come out once every few years. I don't know about you, but like I feel like something big and exciting is happening almost every single month, like in the world of tech. And I'm wondering if that's a good thing or not so good thing for clinical medicine, in the sense that I feel like it could be a good thing just because you have so many different emerging technologies coming out, and combining them to tackle a certain application can be possible. The other problem is that when you start doing that, maybe you have some like misses as well. How do you think about that?
Yeah, I guess it gets to what's your standard that you design, that you end up designing to, because you can bring a lot of technologies together and incrementally, just ever so slightly, change the outcomes. But the negative side of that, as you're alluding to, is it's a whole new thing that somebody has to learn. It's it can be just bringing something new in can be disruptive. And if you're bringing it in for really small incremental changes, it feels like you're never able to get your feet underneath you to kind of keep up with things. And so when we were really thinking about bringing out the ion, it had to meet certain requirements. It had to be able to get tissue in nodules that were less than a centimeter. It needed to be able to get them all the way out to the pleura. There were a set of very rigorous standards that we were holding ourselves to in terms of the development of that product. Then when you bring something out like that, it's worth the big shift in clinical practice. It was very disruptive. It is in the process of being very disruptive. It has moved the way hospital chains do their diagnostic pathways. It's shifted the relationships between interventional pulmonologists and thoracic surgeons. It's created sort of integral tumor management that runs through practices of several clinicians. If your world as a clinician was disrupted every year to that degree, I would agree that it is it gets to be too much. It's a treadmill, and you just you can't keep chasing it down. But I think really every new technology that comes out has got to earn its way into the clinic. It's got to be so much better than the alternative that it's worth it to do the retraining. So as product designers, we've really got to think about, is it worth the disruption to the clinical pathway, because it's bringing so much patient value, and really setting the bar high for when you're going to bring a product out that has more than just a me too incremental effect.
Yeah, I completely agree with you on that. I think I love what you said there about that the technology has to earn its way in. I think a lot of times, and I would say this, I'm going to go out on a limb and just say this because I've bashed tech plenty of times on the show. I think it's exciting to see new entrants in healthcare, Microsoft, Apples of the world, etc. I think the problem though is that having being in healthcare, people like you and I and tech coming in, is that you have to understand that even if something is going to be better, it's going to disrupt. There's a much bigger ripple effect in healthcare, not just because of the sensitivity of the end user or and participant with being patients, but also like how like hospital operations work and logistics and all these different things. So I think that's like really, really important to keep in mind. You mentioned, using, going away from the watch one, see one, teach one thing to more surgical training where there's like self-guided mastery, like using AI, right? And God knows in my own company, like, I don't know if I would be able to do what we're doing now as an agency without AI. We use it in so many different ways. Do you feel like for innovation from a business model perspective and also like clinical innovation, like developing internal LLMs and AIs where you feed it information and you kind of like co-create to help it identify different opportunities. Do you think that that's, something that companies should start doing more of?
Well, so it depends on what you're really thinking you want to use the AI for. When people are thinking about LLMs, it's mostly generative AI. I want to create content. For training, think of training to be a surgeon, training for the psychomotor skills associated with being a surgeon, as more like learning a musical instrument. It's more like musical training. So it's not necessarily, I know intellectually about how to do this particular procedure. You do need to know that, but you also need to have the physical skills associated with it. And so if we were thinking about using AI to help someone in musical training, we would be along the lines of it sitting in the position of a coach. It's watching or listening and then giving feedback based on how they're playing their instrument, or hold your hand slightly differently, or if you do it this way, or practice this section. So when we think about the coaching for surgical procedures, it's less about large language models and more about what we think of more as an embodied AI, where you've got visual and it's combined with a physical model of the world. And it is also combined with what these are common mistakes that are made. We're seeing that mistake happen. This is the kind of guidance that we can give to refine someone's practice. So AI will not replace, actually using surgical instruments, but it could potentially coach someone to use the surgical instruments in a more precise way. And so we use the term AI as if it just means LLMs these days, but there's so much more to integrating a lot of different modalities. And right now I'm thinking primarily of the AI that we would use in order to coach people.
Yeah, I think that's also, it is very important for general AI knowledge and education to understand like the difference between these things, because I think that's going to guide in terms of not only the data that you're going to be putting in and dealing with, but also understanding and interpreting how it's coming up with those answers. I think there's maybe the art of dealing with AI is as the user being able to decipher and differentiate like certain answers from others and sort of combing through to get to the right things. I think that's like a big difference that I've seen, at least on the LLM side, when you engineer prompts between like, let's say one of my parents, who, by the way, my dad's almost 80 and he uses ChatGPT, but as an example, the things that he'll use ChatGPT for and the question he'll ask it versus like, let's say me, where I'm using it on a completely different level, daily basis and everything. No offense, Dad. So real quick, sort of a pivot here. So another sort of data thing I want to bring at you. So coming back to the numbers from our trusted friends over at LSI. So they had this one headline about the U.S. market strength. And so there's about 95.7 million procedures that have been done, and it's getting close to the 100 million procedure mark, right? But when you look at that in context to other things, like let's say, HIV or malaria or all these different things, right? It's still not as big. But I'm wondering, you feel like one of the big problems is that this sort of lack of access to surgery is a bigger crisis. I think, correct me if I'm wrong, you were quoted on saying that as well, right? That there's that lack of, here we go, yeah, that lack of access to surgery. It's a bigger crisis than HIV, TB, and malaria combined, right? But again, the problem is that it rarely leads in global conversations. Why do you think that is? What's the plan to sort of get attention? I think a lot of these issues get solved through better marketing of getting people's attention first, and then everything else flows from it.
Well, I think it gets to that wicked problem again. So HIV, TB, and malaria are wicked problems, and people are focusing on them using technologies like vaccines and antibiotics or other medications. And those have the kind of characteristic that if you can take a high-tech solution like a vaccine or a medication and you can create it, it becomes very easier to distribute it all over the place. And, if you can get other kinds of vaccines or medications there, you can get these new ones there. Problems like surgical care are multifactorial. It's not that you can create surgical care somewhere and ship it and deliver it to a patient. You need to build the infrastructure in place. You need to build the educational infrastructure. You need to, it's educational, it's healthcare economics, it's the physical plant, it's the transportation system, it is the pre-hospital trauma that gets people there in time so that you can actually operate on them. There are so many factors, and trying to solve them all at once in all of these different places in the world feels like an intractable problem. And so, although more people, so about 17 million people a year, die from postpartum hemorrhage, traffic accidents, surgically treatable and curable conditions. And the reason why is surgery was not available to them where they had that crisis that needed surgical intervention. And when we think about how to compare that to deaths from cancer globally are about 10 million. So 17 million from no surgery, 10 million from cancer, 3 to 3.5 million from HIV, TB, and malaria combined. And so when I say these problems are of different magnitudes, it's never to say that we should not be focusing on HIV, TB, and malaria, or that we should not be focusing on cancer. It's that we should be trying to figure out how we scale access to surgery. And when we step back, we really need to solve that wicked problem of training. Comes back to what we were first talking about, which is see one, do one, teach one, cannot get us to the point where we have enough clinicians trained at a very, very high quality that will ever meet the needs of those patients in the future who, unless we do something different, will continue to not have surgical options when they are in those accidents or when they are bleeding to death.
Yeah, and I think, what's interesting is that this idea of why it's so important to sort of, I use this very sparingly because I feel like it's thrown around a lot. Democratize surgical training is so important because even today, I mean, look, you and I we're in the U.S. In some ways, some of the best healthcare and medical technology and everything is here. But if you and I had a loved one who needed a procedure, I think the immediate knee-jerk reaction is to say, oh, well, who in the U.S. has done the most of these, and where, and it shouldn't be like that. For me, I live in SoCal, but I live between LA and San Diego, and God forbid if I need a procedure, I don't want to think like, oh, I need to go to LA and stay overnight or go to San Diego. I should be able to go within like a 10-mile radius of my home to get a procedure done, whatever it might be, and know that I'm getting the same quality of care and outcomes that I would if I went to Scripps, or anywhere else.
Well, and I mean, you highlight a reality that is there are care deserts in the United States, even in very, very high income countries. There are rural areas or areas that are away from major teaching institutions where the level of care that is available to someone coming in at that point is much lower than would be available to them in one of the cities. And so, the same kinds of problems that we're trying to solve systemically and globally have to do with being able to also have universal care no matter where you happen to be. Now, I mean, the reality is you probably don't want very expensive pieces of equipment that aren't getting constant use at a lower level of acuity hospital. It's not just about all of the resources everywhere, but the practitioners that you see at that hospital should be able to recognize what can I do with the resources that I have here, and when should I send someone on because they need care in another, at another level of acuity. But we and the rest of the world train by pulling people out of the communities that they're in. We concentrate them in areas with medical schools and high-level teaching hospitals. And then we struggle to get them to go back into the communities because they've pulled up all their roots from those communities. So a lot of what we're thinking about in this kind of scalable training, where we're training at the point of care, where we're allowing practitioners to get the kind of coaching they need to increase their skills without having to leave the site of practice. Yes, this is very, very helpful for big rural areas in Africa, but it's also very helpful for rural areas in the United States, where a isolated or more rural hospital that hasn't been able to keep up with changes that are happening in medicine and devices and all of this have the ability to train on site and really get to a very high level of care no matter where they happen to be. So yes, it's not just a global problem. It's a local problem as well.
Yeah, and I think, to make it even more complicated, I feel like these sort of standards have been implemented in other training residencies in the world. But at least here in the U.S., one of the other issues is that, it's not like, when my father trained or when you trained where, you get a lot of exposure and you're doing like 90, 120 hours a week. Now they're capping the amount of time you're allowed to work every week as a resident fellow. And, the first question that a lot of physicians say is like, okay, like, how are you going to get trained in time, to be prepared to do this? And I think this is where introducing technology and new ways that you can practice and learn and implement is going to help accelerate that learning curve.
Absolutely. We saw that, earlier in my career, I was part of putting Stanford's first surgical simulation center together. And one of the things that we were doing research on at the time was efficiency of training. So if you learn to put a central line, which is, a cannulating a large vein so that you can put a large amount of medication into a more central vein. That's the central of central line. People learned to put their first central line in on a patient. And they would be coached through putting it in on a patient. And it would actually take quite a long time to learn how to do this. And you would have to practice on quite a few patients. When we implemented simulation-based training, we made sure that everyone who was coming through our training programs had put in a central line 6 to 7 times on a dummy. They knew how to set everything up. They knew the landmarks they were looking for. They remembered because they'd been through the process multiple times. Oh, yes, I scrub at this point. I numb up the area at this point. I've got my things laid out on the sterile table. That's half of what you're learning, which is just how to set everything up. What happened as they then were required to do multiple practice sessions before they ever touched a patient is the first time they touched a patient, they did it very well. And our pneumothorax rate at the hospital dropped, and our line infection rate at the hospital dropped. And that quiet suffering of patients who are being learned on, most of that disappeared. So now you didn't have 9 patients who had a substandard experience while you learned. You had 1 patient who had an excellent experience when you put your first central line in, and you didn't have to put all of those practice ones into patients. You could practice them one after the other in the simulation center. So I believe that simulation-based training really has a potential for reducing the length of time. You can do you don't have to wait for the thing that you want to learn to walk in the door in the form of a patient. You can train on it. And then when that patient comes in, the learning that is happening by the trainee is at a much higher level than they would be learning if they hadn't done all of that practice. They're not learning how to suture. They're learning the nuances of this particular procedure and how to do intraoperative decision-making. And so we change the quality of the experience of the learner by having them have a lot of practice before they do their first procedure. and we significantly change the experience for the patient because they're not being learned on. And it gives us the ability to actually shorten these kinds of training because you can practice the hard things over and over and over again and not really just be waiting for that to come in the door. So I feel like that one's one of those win-win-win. And what's pushing us is to get away from the see one, do one, teach one for demographic reasons. But I think it will really improve outcomes for patients. It'll improve the experience for the learners, and it will improve the efficiency, the pace at which we can train high quality surgeons.
Yeah, and I think what's going to be interesting on the topic of training is to see what things we kind of come to terms with and say, okay, like we don't need to train to this level anymore because we have more than enough technology. I think there was a time and period where you were, at least when I think about my time in medical school, where we were at the cusp of where you didn't have to spend so much time practicing getting a blood pressure by listening, because it's like we have plenty of devices to do that. You don't have to waste. And that's like a tiny example of things. And I think that for clinical training, is, especially surgical training, there's certain parts of surgery where it's like, okay, is it good if you know how to do something manually or on your own without any technology? Sure. But there's so much technology that we have. Like, it's going to be really rare where you don't have access to XYZ type of tool or this technology. And I think when you do that and compound it over time, you end up eliminating a lot of training time set for those things and more training time for like the most important parts of the procedure where you need that operator to have that sort of experience with technology. Is that the right way to think about it?
I think it's a good way to think about it. When you think about what people are developing with repetition and seeing multiple variations of things, is they're not just building their psychomotor skills, the actual physical capabilities. They're also building clinical judgment. And in a lot of ways, without imaging or various kinds of feedback, you built that clinical judgment overseeing 1,000 cases like this, and very subtle clues that you could see would indicate that, oh, this person has an anatomical variation or this is behind that. But giving people certain kinds of imaging so that they know exactly what they're going to encounter when they get into that procedure means that they don't have to have necessarily the skill to recognize what it's going to be. They know what it's going to be because it's been imaged. And so that moves people up that learning curve also by us being able to use certain technologies to aid in intraoperative decision making, to make it clearer what it is that you should do, to be able to support the decision that the clinician is making so that they make the right decision and do the right thing for that patient. And that judgment can take years to develop beyond where you've developed the physical skills to do the procedure. And so if we can shortcut that, shortcut sounds like a bad term in this space, but really we're just accelerating people's ability to make the right decision. And whether that comes from a wealth of experience or from something that they can see intraoperatively and it gives them the insight that they need to know the right thing to do, I'm not sure it matters for the patient as long as that patient had the right therapy that was given to them.
Yeah, I completely agree. And I think also the way we think about things, like I think in medicine, when you hear the word shortcut, there's like sort of a negative reaction to it. But technically, if you think about what Intuitive did with radical prostatectomy, I mean, that was like the shortcut of all shortcuts, but it made things a lot better for the patient at the end. And, again, took a procedure that, I don't know, what was it, like less than 2% of surgeons were able to do at the time, to really democratize it to like a lot of surgeons could do it. And again, solve the problem of access, for patients.
Yes, it allowed prostatectomy to be a minimally invasive procedure. And you didn't have to be the laparoscopic whiz with years and years of experience under your belt and a lot of learning cases under your belt as well to be able to give an excellent, minimally invasive surgery to your patients. And so, yes, we don't like the word shortcut, but it is something that allowed that clinician to do a better procedure for their patient in a way that was tractable to learn, unlike unlike the options that were available before them.
Right. And Dr. Morgan, I really appreciate you spending some time with us. I do have like one last question, kind of a fun one, but again, you have an amazing talent stack in terms of your experience, your training, your education. So you've moved between like engineering, surgery, and venture, and strategy, and all these different things. When you look at medtech as a whole, in terms of how medtech leaders are doing things and thinking and solving global health problems, is there kind of like a myth that you feel that needs to be dispelled? Because I'll just say, from the marketing and commercial side, there's all kinds of stuff that's just complete nonsense that I'm trying to dispel on mine. But for you, in terms of where you sit, is there like one big one where you're like, yeah, we got to rewrite this thing. This is not really how it goes.
Yeah. I think the biggest myth in the global health area, where, we're trying to solve some of these very big problems, big demographic problems. I think the biggest myth is that you can think about scale after you've thought about the solution. We see lots and lots of people piloting solutions and showing again and again that if we throw resources at this environment where there weren't resources before, that lo and behold, people are trainable and that we can train all of these very brilliant people to be excellent clinicians. And when we give them all of the tools, their patients get really good outcomes. And then all we have to do is just replicate throwing resources at everybody, and voila, we've solved the problem. And this is such a pervasive myth that somehow that approach is going to solve this problem. You have to think scale forward. You have to think, how do I make it possible that every clinician could be teaching themselves simultaneously how to do this with no increase in our resources? Training one or training 10,000 is the same effort on our part. And if we can get to holding ourselves accountable for scale, and how will that scale, before we then go do all of the pilots, I think we'll go a long way towards dispelling this treadmill that we're on of the endless series of pilots.
I'm so happy you said that, and I completely agree. I think our industry gets sort of enamored by things in tech about scale and all this and moving fast. I'm gonna, one of my, early marketing mentors was Seth Godin. And one of the things that he talks about is that, like, when it comes to solving problems, you got to first solve a problem for like a couple of people. Because if you can't solve that problem really well for a couple of people, what makes you think you can do it for like 10 or 50 or 100 or 1,000? And it's like, it's not like things get, it's not like the problem's going to change. It's just going to get more difficult.
I mean, I think in a way, those two are a little bit opposite of one another, in that what we see is people go out and solve it for a couple of people, but in the same way that it's been solved over and over and over again for a couple of people. It's not a new solution. It's the same solution. And the answer is, and we just need more resources. If you can train a couple of people with this new technology, but before you even started developing it, you knew that technology was inherently scalable, that's the correct order. So, all due respect to Seth, I absolutely think he's right, but you should first solve it for a couple of people with an inherently scalable technology.
Sure. Yes, that I agree.
That.
So I completely agree with you on that. Well, Dr. Mohr, thank you so much for spending some time with us. For the listeners, I'm going to encourage you, go follow Dr. Mohr on LinkedIn at Catherine Mohr. You also have a website. What's your website? Plug your website.
www.catherinemohr.com. So
there we go.
Run together, no punctuation.
Perfect. And then for those interested in learn more about the Intuitive Foundation, you can go to intuitive-foundation.org to learn more. And if you enjoyed this episode, forward this on to somebody. A lot of our Actually, the majority of our listeners are not even subscribers. They discover the show. So thanks to you, to the audience. Be sure to like and subscribe. Give us 5 stars. As always, I'm your host, Omar Khatib. Dr. Mohr, thank you so much for joining us.
Thank you. Thank you so much. And for the interesting questions.
Absolutely. All right, everyone, take care, and we'll see you next time. Thanks for checking out this episode. If you want to do me a big favor and join so many other people who have helped grow this podcast, take a second and look below. If you're on Apple, give us 5 stars and write a short review. If you're on Spotify, just give us 5 stars. And if you're on YouTube, hit the like button. And most importantly, if you can, subscribe. We release so many different episodes that you may miss. Be sure to subscribe and turn your notifications on. You get extra points with me if you subscribe across all 3 channels. Thank you so much. And if you felt like this episode helped you, send this to somebody who'd really enjoy and appreciate it. Share and spread the love. We'll see you all next time.